Hi. So one of the things I do a fair amount is go around and talk to chambers of commerce, and I've actually gotten into the habit every time I go into a small business. There's a place that I go to all the time for lunch, and I talk to the business owners to kind of find out what's going on with health insurance and how do you deal with that. And again and again, I'm sure I'm not telling anybody here anything, that what I hear is kind of two things. Number one, it's a huge problem for everybody, and it's a huge problem because it's a competitiveness issue, because in order to attract and retain good qualified employees, providing good health benefits is a huge issue. This place where I eat all the time in Albany, if anybody knows it, Shalimar's, really good Indian food. He's opened up a whole bunch of new shops, and he had this bookkeeper who had been with him from the beginning, and he was really trying to grow his business, and he just lost the bookkeeper because he's starting out a family, and he can't. The larger firm could offer better health insurance, so it's a real issue out there. So I know I only have a few minutes and we're running behind. I'm just going to outline a couple of things that we've done already, and then talk about what's coming up and highlight a few of the issues that I would expect to see over the course of the next year or two, relating to small business and coverage generally, because of course small business owners and their employees are people, and so the things that we're doing to make insurance more affordable generally are going to help small businesses. A couple of the key things many of you may know already that we have done to expand coverage include making Child Health Plus available up to 400% of the federal poverty level. That's about $88,000 for a family of four. So really affordable, accessible coverage for children in New York shouldn't really be an issue, and we should be able to cover everybody. And we did that with state-only dollars, even after the former Bush administration denied us matching money, but we've done that with state-only dollars, Child Health Plus to 400%. We also recently passed a bill extending COBRA benefits from 18 to 36 months. Some other states have done this. It doesn't cost businesses anything, but when businesses do have to lay people off, the employee has access to those cheaper group rates, which in a high-cost state like New York is a real and meaningful benefits. So that's another thing. And we've also made insurers offer coverage on a COBRA-like, where the insured has to pay the premium, but up to age 29, children are able to go on to their parents' coverage and get that cheaper group rate, although they have to pay the premium, so that the businesses isn't paying it. But those are all ways that, and we've got a lot of calls at the insurance department about that, and those are all ways that we've been expanding coverage. There's others, but in the interest of time, I'll leave that on. We've also, of course, operated Healthy New York, and that's been, given the limited funding of the state, it's been a huge success, and there's quite a number of small businesses that have been able to purchase much cheaper insurance because of the Healthy New York program. We started a new pilot program to build off the success of Brooklyn HealthWorks. In upstate New York and Syracuse, we have a new one, and that's dealing with an 8-county region in central New York, and off to a really good start. I'll just say also what we've done so far to try to lower the costs of insurance to small businesses, to all businesses, because as you know, business at the end of the day pays these costs. There's a number of different steps that we've already taken, and I'll highlight just two of them. Number one is, as you may know, Medicaid is one of the biggest payers in the state. About 22% of all health spending comes from Medicaid. One of the things that we realized when we came in as part of the Spitzer administration a few years back, when we all were new and we started looking at the Medicaid budget, so we realized, oh my, the spending in Medicaid has nothing really to do with it's kind of unrelated to actual patient care. It doesn't follow the patient, and most of that are huge portions of the Medicaid funding and the Medicaid budget really can only be understood as in successive budget years where grants of money have been made to different hospitals and institutions. So one of the reforms that we fought really hard for is to better make Medicaid money follow the patient, which doesn't seem like a real radical idea, but as you know, provoked a lot of TV commercials that maybe you saw where it was made to seem that the state was going to be shutting down hospitals en masse. But really what we were trying to do is get a more rational way to spend and account for a lot of that money. And we've made some huge gains. And if you want to ask me questions, I can talk about some of the particulars on that. But one of the premises of the Medicaid reforms, which is also true in a really interesting pilot project, if nobody knows about it, we've been working very closely with the Department of Health and commercial health care providers, as well as Medicaid and providers, clinics, physician offices, and hospitals in the North Country to institute really one of the first and most, I think, forward-thinking projects on restructuring how we pay for health care. It's called the Adirondacks Medical Homes Project. And it starts with the premise that you get the system you pay for. And in New York, like many other states, the system has been set up over the years based fundamentally on Medicare rates, which are often the basis for a lot of negotiated rates between health plans and commercial health plans and providers, and of course the government as well. These rates that pay very well for inpatient and specialty care that do not track outcomes and quality measurements. And so one of the things we're trying to do in this project is to pay for care coordination, to pay for quality, and to get all of the providers and all of the payers, the health insurance companies, in on the same page in a project to really restructure the way that health care is paid for so that we can make it more efficient and try to reduce costs over the long run. So those are a few highlights on things that we've done, and now I'll just mention a couple things about the future and what's coming up. Obviously, the big picture is federal health reform. And as you know, the House may know, as the House of Representatives already passed their bill. The Majority Leader Reid just announced yesterday his bill, and that's going to be coming up for a vote at some point in the near future, hopefully by the end of the year in the Senate, and then we'll be moving on to a conference probably over the winter. So who knows, but maybe before spring we'll really have some legislation passed. And having been in D.C. Several times over the last month and talking to staffers, there is certainly a feel that something real is going to happen. So what are some of the big components of that, and how would it affect New York? And we kind of know what they are, and we know to a large extent how it's going to affect New York, because we in New York have a program that the governor initiated a number of years back called the Partnership for Coverage, where we hired the Urban Institute, it's really smart people from MIT, to model a number of changes, to large-scale, big-picture changes to the healthcare system, ranging on one end to getting a single-payer Medicare for all system, eliminating insurance companies. What would happen in New York if we did that? And on the other end, what would we do if we kind of took a more Republican approach and deregulated en masse, got rid of mandates, got rid of everything, and let the market run its course? And then a number of options in between that. And one of the options in between was what we called the public-private partnership, which was based on the changes in Massachusetts, very similar to what's in all of its major components to what's being discussed federally.